This is Bob Leahy from Positive Light, and we're here in Montreal today at the National Housing and HIV Summit, and I'm talking today with Sean Rourke. Sean, people know probably quite well. Sean is the Research and Executive Director.
I'm actually the Scientific and Executive Director.
Oh, you've got it right, I guess. He's that. And I always get that wrong, but that's okay. Tell me, Sean, you've been talking today about the connections between the OHTN's work on housing and health outcomes. Tell me how the OHTN got so heavily invested in research on housing in particular.
Well, this started back in 2004 when I had taken over at the OHTN as the Scientific and Executive Director. And at that time, we were really trying to rethink what the OHTN was going to do and how it was going to invest in research that was going to make a difference in the lives of people living with HIV. And as part of that, I started to get myself around people that really understood what's happening at the front line. So the community leaders that are part of our network in Ontario meet on a regular basis. And I was really positioning myself into that network to listen to them about what was the most urgent and unmet need, and that was housing. Mm-hmm. And so when I heard about that, and I could see these people who were really thoughtful and really visioning about what they'd want to see happen in terms of addressing the needs of PHAs in Ontario.
And that was Jay Kunstra. Was one of them, and the other one was?
So Jay Kunstra, Michael Sabota.
Yes, two well-known names.
Ruth Ann Tucker, Michael Sabota, Ruth Ann Tucker, Jay Kunstra, Laverne Monette, who's no longer with us. And so these are people that actually could see how important housing was.
Right.
And so at the time, we also were redesigning the OHTN and realized that community-based research was something we wanted to invest in. People were concerned what that really meant. But it was really looking at research to have impact. And that, I think, was the way into our housing. That was the starting point of our work. I think that is now almost 10 years later, has had some significant impacts.
Okay. And one piece that many people are familiar with is positive spaces, healthy places. Did I get that right?
You did.
Tell me about that, Sean. How does that project look like?
So again, this is a project, a really seminal community-based research project. The first of its kind in a way that had the kind of impacts I think that we all want to see. It's been funded by the Canadian Institutes for Health Research, and that was really the bar. In terms of investing in community-based research, people were a bit concerned about what kind of work that was going to be, and we said we're going to set a very high bar in terms of the scientific rigor of how we'd approach this, but in a way that brought everyone to the table, that we were all working shoulder to shoulder to address this. And so Positive Spaces really got created out of a team of people that were community members, researchers, policymakers, people living with HIV, and so that was the starting point.
And you had, I think, 600 participants you followed over quite a time, and that whittled down to 400. Is that the sort of size of the population?
Yeah, so we recruited 600 people, but we were also trying to over-recruit in some areas, so people coming from Aboriginal communities, women, particularly moms who had kids, and to look at those people, follow those people over time. And but that 600 was a number that we were funded really the first phase for just a one-year study. And then we went back to CIHR and got funding to follow people for 5 years. So we're actually the first study that was refunded by CIHR to actually look at these outcomes. And really what's important is that housing is something that's integral, is a determinant of health that's connected to so many other things. And so we really wanted to try to understand what happens over time, with the understanding that this information would be very helpful to planners and policymakers and service providers, and really we want to get those results into their hands to help make change.
Yeah. So the concept was you followed their housing situation and how they felt about their housing and tracked it against their indicators of health and wellness and mental ability and all those kind of factors. Is that right?
Exactly. And so we were studying not only the structural elements of housing, what kind of housing a person is in an apartment, in a house, on the street, in a halfway house, but also how they felt about their housing. Because really housing is about, or what's housing we're learning is very important, not just in the structure, but that it's a place that people can call home. Yes. So people have it's a place that they feel safe, that's affordable, and so that was really important to understand the qualitative elements. And we've done a lot of work to to tease out those important pieces, which are both are very important.
So it's not just housing, it's suitable housing and housing that they feel comfortable in and is a good place for them and to be healthy.
Exactly.
Yeah, I think I got the concept. All right. So what were the kind of outcomes of that research? What have you learned from that particular piece of research?
So I would probably frame what we've learned into four main areas, and I think this is what our work with the Housing Summit folks has helped to document as well. And in fact, just to roll back the question a bit or the story, that when those frontline executive directors were trying to understand housing and what it meant, they turned to the Canadian literature and it was nothing. There was lots happening in the U.S. So we've now changed that. And in fact, we did a systematic review trying to understand what kind of studies were out there back in the 2000s, in the mid-2000s. And there was only about 16 studies at the time that showed the relationship between housing and health. We've recently redone that, and now there's over 100 studies. So the evidence is building. But all of that can be summarized into probably four main areas. First is that housing is prevention. And so there's a lot of different ways of thinking about that, looking at it. But housing is clearly a very good and very effective prevention strategy. The second thing is housing is health. And so we've been talking a lot about that. And there's different ways of looking at what health is, and both the quantitative and the qualitative aspects of a person's health. Housing is also very good health care. So if a person has housing, they're better able to access the health care and support the HIV management and all those things. And lastly, housing is really good policy. And so with all the work that's happening, those are the messages that when we sit down with frontline folks and health planners and policymakers is to really lay it out for them that this is what we're finding, and this is when you pool everything together, there's very consistent messages across those forms.
So that's a very good case. We've also heard this afternoon that housing is a human rights issue too. That housing is a human right, so that adds to the strength of your case too.
Exactly.
Okay. I want to talk about. We know housing is a big factor in people's stability and mental health and wellness and longevity. And I think you've done some research on morbidity, have you not? How long people live if they're in stable housing compared to homelessness. What have you found about that?
So when you look at what happens to people in terms of adverse health outcomes or morbidity and then mortality or how long people live, we were struck by. This was one of the main objectives of following people over 5 years to see what happened. And we went back to CIHR for funding because we were concerned that even within the first year, there were people that were not living normal lives. And so it made us think about this is something we should be paying attention to. And a lot of epidemiological studies study people over 5 or 10 year periods. And so this is something that we got funding to study. And it's something that we found in our preliminary results so far is that about 10% of the people that are in our study have passed away. And when we looked at that number, there was a couple of things that were really striking. First, that's a rate that's certainly very much higher when you compare it to the people who don't have HIV in the province of Ontario.
I think we had 3 times higher.
Yeah, 3 times 4, and it actually goes up depending on where you live. So that's the first thing is it's several-fold increased, several-fold higher than you'd expect. The second thing is where you live or geography is important as well. So if you live in Toronto, there's a slightly higher rate of mortality in Toronto for people living with HIV, but it's even higher in the East. And this is very concerning because in Ontario we have a system that should provide equal access across the province. But I mean, if you talk to folks at the front lines, they'll say a lot of people, access to care is something that we think is equal or accessible across the province, and that may not be the case. So our research is telling us that mortality is something that we need to pay attention to. People are also dying at a rate much higher in the earlier years. And that's even more concerning. So not only does geography, but people in their 40s and 50s are dying at rates that are extremely higher than compared to their peers.
Okay. Sean, I can ask you, are you able to track the homeless? Like, that must present particular challenges, isn't it? I know many people change homes over time, but what about the people who live on the street? Are you able to bring those into your sample?
So our sample is actually mostly people who are not on the streets. And so if these numbers are such that we're able to follow people, the numbers could be perhaps worse.
That's what I'm thinking.
In those people who don't have access. And so that's something that we need to look at.
Right.
Unfortunately, we haven't done that in a really systematic way. There's some good people that are doing that kind of work in other areas of homelessness, but we haven't done it through the HIV lens yet.
There's particular challenges in tracking the homeless and keeping track of them, and over time particularly.
And here at the summit, I mean, it's clear from the U.S. data. If you look at Josh Bamberger's work, and he has very good data from San Francisco showing that people who don't get connected into housing or homeless die at a significant rate across those 5 years.
Yeah.
So.
Sean, I'm going to ask you, there are many factors that influence people's living with HIV's health, and housing is one of them. But we've also heard that food security and good food is also very instrumental in health outcomes. And there are other things too. How do you sort of separate? How can you say how easy it is to advocate for housing when perhaps it is, there are other factors like food security that are equally impactful and may in fact be sort of impacting on the mortality and morbidity rates that you're talking about?
Excellent question, and I think we sort of anticipated early on that when we thought about housing, and this created a bit of a challenge that as researchers we'd like to ask a lot of questions, but we realized up front that housing is one determinant of health in the context of many, and so in our studies we've been asking about housing, but also about food security, about these other elements, and so we've collected that data, and now as part of our other work we're looking at how these are related to each other. And I think we really need to be talking about housing in the context of these other factors. And so we're doing that, and I think we'll have some data to share shortly about that. But I think it's really important. People make decisions about whether they put food on the table, whether they support their kids or put a roof over their heads. And we know that from our data that's a decision-making piece that people have and make. And so this is important to understand in the context of all of those things, as you point out.
Right.
You can't just look at one without looking at the other. And some people may be able to buffer these things depending on their networks and their social supports and their access to services more than others.
Right.
And so this is something that we need to now contextualize it better so that we can, because I think what the questions you're asking will help us lead to more solutions about where to act. And so one solution is obviously provide housing, but another may be to have more income supplements to help that balancing act of both food and housing.
Okay. Sean, you mentioned solutions. Let's move on to solutions. You've done a lot of research. You've been going, I think, for 7 years now. Are you starting to get into a position where you are able to influence policy, to bring about new housing on the market, to bring some really good results coming from the research? Where are you on that?
So along the way, that was a very important piece for us, is that to share the results early. And so, and for the communities that we were part of and where the data was collected, to bring them back into those communities. And so we've actually been very successful in Toronto, in Niagara, in Ottawa, where the directors for the agencies that have been part of this work have worked with their local health authorities, and to really work with them to show them the data, show them what's happening, and they've been able to secure funding for additional programs. So we've done
through your research.
Through this research, yeah. So this is where research is really having impact on the ground for. And what's interesting, we've also been working at the policy level to help change access to housing support services for people with HIV that also have mental health and addiction. So writing that into the policy allowed those people to have more access. And from that, Fife House and McEwen House in Toronto, as an example, now have dedicated annualized funding to support people with complex HIV and other mental health and addiction issues. So these are the kinds of things that we've been effective with, and really need to spend more time with getting the data enhanced, because I think it's the quantitative data, but also what we've learned is putting that in context in terms of the stories and of the individuals in their communities, and that it's very powerful to have both of those pieces together, and to know and to really work with the people who know the communities to figure out what are the solutions, because housing is often a local solution. It's negotiating how you work within the system, using different levels of government to support those issues.
Right. And Sean, too, I think you have a passion. I think I'm sensing this sort of fits in with the OHTN's role. It's very much about turning research into practice, and this is, I imagine, this is why you personally have sort of seized onto this and like this project. Is that fair to say? It's a good match with your personal objectives and also the OHTN. Is that fair?
It's very fair, and I think this has been an incredible learning experience to understand how to use research and data, and how we need to bring everybody together to think about how we're all going to solve it. And so we're moving into a new place at the OHTN where we want to move not just to study the problem, but to solve it.
Yeah.
And so we're creating this framework of implementation science and program science that will create a space for how do you influence science and practice, both back
and we're
forth.
doing the same with smoking and people
Exactly.
with HIV. Similar, we're trying to take the research and do something with it and do some good with it, and that's what you're all about these days, isn't it?
Exactly.
Yeah. Okay, Sean, good talking to you. Thank you for being so forthright and interesting. And this is Bob Leahy from Positive Light, saying goodbye from Montreal.